Good day, my name is Nadia Lopez, and today I'm gonna talk about risk prediction for acute kidney failure. Definition: acute kidney injury, formerly known as acute renal failure, is a syndrome characterized by the rapid loss of the kidney's excretory function, and is typically diagnosed by the accumulation of end products of nitrogen metabolism, such as urea and creatinine, or decrease the urine output, or even both. New diagnostic techniques like renal biomarkers might help with early diagnosis.
Acute kidney injury, or AKI, is when the kidney is not functioning at 100%, and that decrease in function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF, but AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types: pre-renal AKI, meaning the cause of the kidney injury is coming before the kidneys; post-renal AKI, meaning after the kidneys; or intrarenal AKI, meaning within the kidneys.
Applications in medicine. The Acute Dialysis Quality Initiative (ADQI) work group developed consensus around principles for the design of automated AKI detection to produce real-time AKI alerts using electronic systems. AKI alerts were recognized by the work group as an opportunity to prompt earlier clinical evaluation, further testing, and ultimately intervention rather than as a diagnostic label.
This slide depicts the fist percussion test over the kidney at the costovertebral angle for kidney disorders. A positive finding on this test would be pain with a firm thump of the fisted hand. If you suspect that there could be a kidney disorder mimicking musculoskeletal pain, the fist percussion test can be utilized. You palpate the costovertebral angle at the 12th rib. Place your non-dominant hand over that costovertebral angle, and testing the left kidney, you produce one firm thud over that area. To test the right, you palpate the right costovertebral angle, move the hand over that area, and again, a firm thud. This should be painless, though the patients will feel the pressure of that force. If there is a kidney disorder, patients will often report pain.
Pictures. In the first picture, we can see a kidney with kidney stones. Kidney stones can develop acute kidney injury. In the second picture, at the right, we have a chronic kidney injury. In the center, we have a normal kidney, and in the left, we have an acute kidney injury. Pros and cons. Pros. Improvements in patients with acute kidney disease often occur with serum controls for urea, creatinine, and protein in the urine. Electronic devices are also used, but they are very new in medical network. Cons. The AKI controls have to be done very often to control any abnormalities in the kidneys, and therefore turn out to be very expensive, and some patients do not follow the complete control of their disease.
In terms of the ability to reverse your kidney disease, it really depends on the cause of your kidney disease. Is it something transient, like an infection, like a medication that you shouldn't have taken? And in those cases, you take away the insult, it is possible that you reverse your kidney disease. but it also depends on whether you had underlying kidney disease to begin with. But unfortunately, for most of our population, the reasons for kidney disease are longstanding, such as hypertension and diabetes. And unfortunately, those are not reversible, and therefore the kidney disease is unreversible. Unfortunately, there's no cure for kidney disease, but there are ways to slow down the progression of kidney disease. And this is where keeping in close touch with your healthcare professional becomes crucial. It is important that they keep tabs on your blood tests, on the status of your health, how you feel, so that the progression does get slowed down as much as possible.
Issue applied in Ecuador. In Ecuador, the prevention of acute kidney injury is handled in the following ways. Consists of the prevention of the disease, slowing down of its progression, adjusting the medication dose according to the glomerular filtering rate, treatment of its reversible causes, management of complications, identification, awareness, and adequate preparation of the patient for the start of therapy renal replacement.
This video is going to be on urea and creatinine physiology. And first I'll start off by talking about urea. So urea is derived from proteins, amino acids, or ammonia. And these can be either metabolic processes or absorption through the GI tract. But whatever the source, the ammonia that is derived from these substances eventually makes its way to the liver, and the liver converts the ammonia to urea. The urea is then excreted out into blood, and it's excreted from the body by two different routes, either the kidneys or the GI tract. And I'll start first talking about the kidneys. So the urea is freely filtered into the glomerular ultrafiltrate, and most of the urea makes it out into the urine, but the tubule does resorb some of the urea, and that urea makes it back into the blood. So again, urea can also be excreted by the gastrointestinal tract, and it can eventually make its way out into the feces, and I have drawn here a rumen and colon. But it can be excreted in any species, so dogs and cats as well. It can make it out into the feces. But I have the rumen and colon drawn because when the urea makes it into those areas, the bacteria that live there can convert that urea into ammonia, and the ammonia can be resorbed and make its way back into the body. Now, when it does this, this is called urea recycling, and this is the reason why urea is not as good as a marker for GFR in large animals compared to creatinine. Okay, so now I'll talk about creatinine, and fortunately, the physiology for creatinine is much more simplistic. So creatinine is a muscle breakdown product, and about equal concentrations of creatinine are released into blood each day and over time. And that creatinine is freely filtered by the glomerulus, making it into the ultrafiltrate and into the urine. So now I should note that creatinine is not used as a marker of muscle injury. The kidney is very good at excreting creatinine, so if you have a normal functioning kidney, then you shouldn't have buildup of creatinine with muscle injury. It is possible to get buildup of creatinine if you have renal insufficiency, but a normal functioning kidney, you should not have it with muscle injury. So the marker that we do use for muscle injury is called creatine kinase, or CK, and you'll learn more about that enzyme later.
Conclusion. In conclusion, predicting risk for acute kidney injury is key to avoiding complications in treating the disease. As the kidneys stop working and filtering products of our metabolism, such as proteins and waste products like urea and creatinine, leading to kidney and blood toxicity. There are many ways to keep track of the renal function, such as electronic devices and serum controls for urea and creatinine. Glomerular filtration, clarification of inulin or TC-DPTA are important in the clinical routine. Thank you so much for watching.